Yes. If stream starting, good morning. One sec. Good morning. Posture is very, very important for me and for you as well. Most of our back pains, neck pains are mechanical in nature, and our bad posture may be one of the reasons. Especially for you guys, for the last 6 months you are enjoying stay at home, so never bothered about your posture. So, but do take proper care. Today we are going to discuss something about polytrauma, how to manage. Till now, you have learned various fractures and how to manage them, what are the complications, and how to take care of them. But today we'll discuss the common scenario in our orthopedic practice. That means, thanks to our excellent roads and senseless drivers, we have trauma as a bread and butter for orthopedic surgeon. And nowadays, even jam is also added to that because of their increased accidents rate. So you need to take some proper decisions, and how to go about it we'll see. So this is a backdrop of Usmania General Hospital, where I worked for some time. I was very fortunate to work in that prestigious institute when I was a medical student doing my undergraduation and post-graduation away from Hyderabad. I was always wondering how it would be if I was a student there, but unfortunately I couldn't be one. But I always wanted to work there, and fortunately I could do it. And this lecture, incidentally, this was a lecture delivered by me in our state conferences. I tell you, because I delivered this lecture in the two state conferences. In 2016, we conducted two state conferences, one in Telangana state, another one in Andhra Pradesh. In 2014, the Telugu states were divided into two, and I studied in all over Andhra, and I identify myself as a pan-Andhraite rather than to belonging to one particular part of the state. For that, I paid my price as well. Though I got qualifying marks initially while joining MBBS, I was denied admission because I was non-local throughout the state. Even when I was given a professor promotion also, Telangana people considered me as Andhra fellow, and Andhra state people considered me as Telangana. So I never bothered about it. But I was fortunate that mine was the inaugural lecture in both state conferences. So I take great pride in that, and that usually don't happen to each and every one of us. But I was very fortunate because my topic was most essential for everyone. That's why, otherwise they did not do me any favor. This is the topic which was important, and they had to accept it. That's why I prepared this when I was in Usmania General Hospital, and with a lot of difficulty and with a professional help, I could get this photograph, the panning view of the Usmania General Hospital when I was there. But now I think it has gone to docs, and I don't know what is going to happen to it. So let's jump into our topic today. Enough of introduction. What is polytrauma? Polytrauma, all of us know that it should be multiple injuries, multiple fractures should be there, and multiple systems should be involved. Apart from fractures, a lot of things can happen in polytrauma. There may be a head injury, injury to the thorax, intra-abdominal injury. So many systems are injured. Then we say usually that's polytrauma. And there is one thing called injury severity score, that is ISS. And we give points for each injury which is present. And if the score is more than 70, then definitely we say that it is a polytrauma. So this is textbook definition of polytrauma. And this injury severity scale is very, very important. So whenever the patient comes to you, apart from giving first aid, you need to assess all these things. And there could be some systemic reactions. It's not only the injuries which will kill the patient, but the body's systemic response and is very, very important. Nowadays we see people talking of cytokine storm and so many things which kill the patient in a COVID patient. Yeah, it's your body's immunity which is killing you. It's not the virus. It's very surprising to know that people are thinking that virus is very, very powerful, very, very dangerous, and it is killing right, left, and center. No, it is inducing a inflammatory reaction or a immune response from our own body, which is much more than needed. When things are more than what they should be, then all hell breaks loose. The same thing is happening. The cytokines, some of them which are protective, are released in a unnecessarily large quantities and which have their deleterious effects. And unfortunately, they are injuring the primarily uninjured organs. See, kidney has nothing to do with these injuries. In polytrauma, kidney is not injured, lung is not injured, liver is not injured. But unfortunately, what happens in a polytrauma patient, if you are not careful enough, or if the injuries are very severe, then they may fail. The failure of the remote organs is much more dangerous than the injury which occurred at the site of accident per se. So your treatment, the management should encompass all these things. You should take all these things into consideration and treat the patient as a whole. It's not enough if you treat a single fracture. It's not enough if you treat a lung injury or a liver injury. But you need to take the patient as a whole, and you need to prevent this injuring the uninjured organs and vital systems. Some of these are very, very vital for survival. And if they get injured, then it is very, very difficult to save the patient. Coming to the management of this polytrauma patient, basically we follow this ATLS guidelines. ATLS, all of you know that, acute trauma life support system. And all of you as a medical student, you should know and you should undergo the training for ATLS. Because if you are a doctor, if you see an injured person lying on a road, if you don't know anything about ATLS guidelines and how to revive a patient, you are not a doctor. And need not be a doctor to save a patient. Even these first responders like fire workers, the workers working in the fire department, or ambulance, the personnel who are in the ambulance, or the police, all these people should be made aware of these guidelines, and they can save the people. In the West, there is an excellent system that these first responders are very well trained in these guidelines, and they can easily save your life. So once you click on 911 outside India and tell them the emergency, and if there is any medical emergency, within 15 to 20 minutes, the help will come to you. And if there is a stroke or a myocardial infarction or whatever it is, and they can do what is relevant in the first aid and shift you properly. The same thing we want to reciprocate here in our country also, and steps are being taken in the right direction, but it's a long way to go before all of us are trained in this. And now all medical students and interns, I think it was made compulsory to undergo BTLS, basic trauma life support, and this is the advanced one, advanced trauma life support system. So this is a must for all of us. Then this is the dilemma. Whenever a polytraumatic patient comes, more than one consultant will come into the picture. An orthopedic surgeon will come, a chest surgeon will come, and an abdominal surgeon. All of them, we sit together and take a decision which is more important to do. So that decision is very, very important in saving the life as well as the limb. So I should not be stupid enough that just because I can shout louder than these people, I want to fix my limb at any cost. No, that should not be. I should see the patient as a whole. Patient's life is very, very important when compared with the limb. So these things have to be balanced. That is how you do these things. This is all about how to take those decisions. That depends on the personality of the injury. So that means it's not the personality of the patient, it's the personality of the injury. And patient factors, patient's age and his comorbidities, and his soft tissue, extent of soft tissues, and fracture pattern, all these things have to be assessed before you take a decision about what to do and which one to do first. So because the patient may not be in a proper condition where you can do everything at one go. So the patient may have to be treated in stage wise. So you need to know which one comes first. Unless you do that, then difficulty will be there, and there will be friction among the consulting doctors, and unnecessary loss of complications and unnecessary loss of life may be there if the management is not proper. So it is always life comes first. Then once you revive the patient, don't be in a hurry to just operate. The surgeons, as all of you know, have for everything there is only one solution with them. Being a surgeon, I don't mind accepting the fact that we feel very happy with a knife in our hand, and we want to wield the knife whenever we are in a spot of bother. But to wield the knife, you need to have proper conditions first. Otherwise, there will be a lot of complications. So save the life first and think of surgery next or sometimes last. So that is very, very important. Coming to the number of deaths which can occur, or the time of death, usually immediately at the site the peak occurs, because some injuries are very, very fatal. Some injuries, like injury to the chest, direct injury to the heart or to the lungs, no fracture can kill you. That is why orthopedic surgeons are pushed back, and we are very low in the priority of things from an anesthetist point of view. And that's why we usually resent that's a professional part of things. But here there are three peaks in the distribution of deaths. That's why it's called a tri-modal distribution of death. Immediately after injury, the deaths are very, very high. And next one is early. And if you don't take the patient to hospital in a proper way, or you don't treat him properly in the initial stages of his admission, then you may lose the patient. That is early. And in some time, even after admission and even after looking after him for a few days, patient may die because of late. There are some complications, could be some complications, or some secondary hemorrhage or infection. So many things can lead to late deaths of the patients. For patients who are admitted with us and patients whom we are taking care, if you lose them, then definitely you feel very, very bad. Then you should take a decision, proper decision, what to do now. Like in life, even in trauma, there are very tricky situations where you need to take a proper decisions. If you don't take a proper decision, apart from your career and other things, it's the life of the patient which you may lose. Coming to the decision making, there are two things which you can do in a polytrauma patient. These things are early total care. Other one is damage control orthopedics. When the patient has some fractures and the patient is relatively stable, there is no immediate threat to his life, then definitely you can do what is known as early total care. That means you can treat all the fractures in a way that nothing can be done further. No need to do anything after your initial care. That is early total care. That means you can fix an implant if it is a femur, intramedullary interlocking nail, or if you want to do a plating for forearm, you can go ahead and do it and be done with it. You need not think about treating the patient again. So that is early total care. But unfortunately, it may not always be like that. A polytrauma patient coming with multiple fractures may have some problems with other systems. Then patient has to be revived, and patient's life, as we have already seen before, patient life has to be saved first before you think of fixing your fractures. Then this damage control orthopedics kicks in. So what is this damage control orthopedics is all about? As the name itself indicates that there is some damage with which the patient has come to you, and before you embark on doing everything for the patient, first you have to control the damage. That means you have to save the patient first and do the treatment next. So before you take a decision, you need to consider some factors which can affect the well-being of the patient. So there are some three important things which can lead to deterioration of the patient, or patient may not be able to be saved. So these things have to be taken into consideration before you think of operating on the patient. So you need not be pig-headed in just because you have seen one fracture. At any cost, I want to fix that. That attitude has to go. So every orthopedic surgeon, till now you have seen all the fractures and how to manage. But now you are in a situation where you need to know what all things you need to know before you want to go and do the surgery, which you know and which you are itching to do all these days. So the lethal triad is, one is hypothermia. As soon as the patient is injured and lying down on the road, immediately the temperature slowly drops down. So it is estimated that around 15 to 20% of the patient who are brought into the casualty are hypothermic. So that's why immediately after injury, whenever you are shifting somebody to the hospital inside the ambulance, it is always prudent to cover the patient with a bed sheet so that patient will not go into hypothermia, because hypothermia inhibits coagulation and sometimes it may lead to coagulopathy, and coagulopathy will lead to acidosis. So hypothermia, coagulopathy, acidosis, all these things are interdependent. So if one is there, they are very close friends. And these three are called lethal triad. If they are present, you need to correct them before you attempt to do surgery in the patient. And apart from that, you need to assess the soft tissue injury. If it is an open fracture, all of you know that you should go for a temporary measure like external fixator, debridement and external fixator. And in most cases, external fixator may not be the definitive treatment. So you need to do something else after the external fixator is removed. You remove the external fixator and you put the cover. That means you give the muscle cover, you give the skin cover, then you go in and do a plating or nailing. So all these things have to be considered before you even consider the patient for surgery. So this damage control came into orthopedics. This word was commonly used in US Navy. For the first time it came into by US Navy during the war, especially during the Second World War. The Japanese and Germans were very powerful, and they were fighting against all the other countries. Most of you know that US was a reluctant participant in the war, and it joined the war very late because its base in Philippines, the Pearl Harbor, was bombed. Then it has no option but to join the Second World War. There the Germans had powerful U-boats and very good submarines, so they used to damage all these warships. Then they had to save the ship, and they had to limit the damage, and they had to carry out emergency repairs even in the mid-sea. Otherwise they will be losing a warship, and losing a warship is not a very simple thing, because apart from loss of so many lives, it costs a lot, and it will take a long time for them to build a warship. So they used to do what is known as a damage control. They used to, at any cost, they wanted to save the ship by carrying out emergency repairs in the mid-sea and limiting the damage and bringing it back to function. So same things are being applied into managing a polytrauma patient. That's why this is called damage control orthopedics. What is the philosophy behind this? So here you need to contain the damage. So whatever has happened at the site of injury, it's fine. So once the patient is with you, so you need to limit the damage. You should take some steps which will prevent further damage occurring because of the original accident. And for that you may have to stabilize the fractures. So it's not enough if you go on treating the patient when the fracture is going on bleeding. If you fix it, then the bleeding may be contained. Like that, you have to take a proper decision whether to fix the fractures or not. But fixing the fractures will definitely improve the general condition of the patient, and it will improve the physiology. So you need to understand the proper physiology which occurs after the traumatic event or any infection or whatever. If you don't understand the normal physiology and improve it, it becomes pathology. Once we join, we learn this physiology and all, and after that we'll go to pathology. Like that, with improved knowledge or with the passage of time, if proper care is not taken, then physiology becomes pathology. So you should not allow that to happen. Then all these things are part of resuscitation. It's not enough if a patient is shifted from the site of injury to the hospital. That is not complete resuscitation. Once the patient comes to hospital, making him ready for surgeries, and even after surgeries, making him put in the path of recovery, that is resuscitation. So you need to take all these decisions stepwise to control the damage and to make the patient better. So here the commonest thing which you need to counter is shock. So this is the basic element of polytrauma. All of you know that most common shock which can occur is hypovolemic shock. But there may be some neurogenic shock can be there, and some head injury will lead to its own complications. So shock has to be treated because it has a cascade. That means a cyclical event. It begets shock. That means once shock is there, then other type will be there. So all these things are interdependent, like other clinical terrible triad. So hypoperfused hypoxic state. All of you know that once there is a loss of blood, that is hemorrhage, then a hypovolemia, then there will be hypoperfusion, then there will be, once circulating blood volume comes down, then the amount of oxygen delivered to the tissues also comes down. That will lead to hypoxic state. Once that hypoxia is there, then the cellular level there will be a lot of changes, because without oxygen it will be very, very difficult, and it may have to switch from one type of metabolism where oxygen is there to other type of metabolism. So all these changes will take place at the cellular level. There the uncoupling of mitochondria can occur, and sometimes if this persists for too long, this hypoxic state if persists for too long, then there will be cellular death. So body tries to within physiological limits, body will try to recuperate, but if it goes beyond a certain level, then body cannot do anything, and it will lead to cellular death. So there are how to identify that the patient is in shock. Is it normal shock or prolonged shock or whatever it is? There will be some biological markers. Because of the presence of these biological markers, we can know what is the seriousness or how serious is the shock, and what are the various options for us and what we need to do. So these are some of the things: tumor necrosis factor alpha, interleukin 6, corticosteroids, interleukin 1, and all these things will are called biological markers. The presence of these things indicates that the patient is in shock. All of you know that the IL-6 has come into prominence with the evidence that it is the cause for cytokine storm in corona patients and all, and they have brought in some biological agents to fight it, which itself is toxic, and we don't know whether the corona is killing or our treatment is killing the patients in the initial stages. Now I think it is more or less stabilized, and all these things can occur not only in a trauma, in any other burns, splenectomy, or overwhelming infections. This is the scenario. So you should know that these are some of the biochemical markers, and so TNF alpha is the first biological marker which is elevated immediately after the injury, and like that steroids, IL-6 and IL-1, all these things make their appearance. So if you go on serially estimating the amount of these things in the blood, then you will know in which direction the patient is heading and what are the various options for you to bring him back. So there is another important word. So this lecture was prepared keeping orthopedic surgeons in mind. So these things may be a bit high funda for you, but there is no harm in learning new things. So they are very interesting, and all of you, I feel you enjoy this, and if you bandy these words in front of maybe your colleagues from other colleges, I think they feel that you are being taught much more than they are. So I think you can just show off if you remember these things. So this is called systemic inflammatory response syndrome. This occurs in all the patients after polytrauma or after burns, splenectomy, or overwhelming infections. This is the one. So how do you know that this is occurring? The SIRS is when you examine a patient, you know that yes, this systemic inflammatory response syndrome is in place. How do you know that? The temperature should be more than 100.4 or below 96. So two extremes will indicate this is one feature. Then heart rate more than 90 and respiratory rate more than 20 per minute, and PaCO2 and WBC count more than 12,000 or less than 4,000, and these are some of the criteria. And if you examine them and find two criteria present for 3 days, then that indicates that patient is in systemic inflammatory response syndrome. So patient is in this phase. So you need to examine the patient 3-4 times every day to note it down and to see whether these criteria are present for how long. So the magnitude of SIRS, so the response depends on the amount of tissue injury. If more areas are injured, then the response will be more. All of you know that that's a common sense, which is very uncommon, you know. And the degree and duration of the shock also increases the if the degree is more and duration is more, naturally SIRS will be more magnitude. And host factors also play a very important role. The extremes of age, that means very small children and geriatric patient, the response will be different than other age groups. And comorbid conditions like diabetes, hypertension and heart disease, obesity, hypothyroidism, all these lifestyle disorders, our junk food makes it very convenient for all these comorbid conditions to come and settle in our body. So those things will play a significant role in the magnitude of the SIRS. So the more the SIRS, the more the damage to the body. So that is like akin to the cytokine storm we are talking in COVID. So here also you can bring this anomaly, and if the SIRS is more, the damage is more. Okay. So all of you know that more SIRS, the number of SIRS who teach you are more, then the damage will be more for you. That means you need to sit in the classroom for much longer. That is the damage for you. That is the damage to the brains, your brains. We try to push in something to the brain which you resist. So the more the number of SIRS, the more damage for your brains. Okay. So that is one. And there is something called a second hit. See, already the patient is hit with earlier injury and we are trying to resuscitate him. And if you are not careful, by your actions, you are hitting him again. And that is called a second hit. So, what is that second hit and what are the things which you should not do in these patients, we'll see. And as soon as the SIRS is inside the body, then body will get ready for the next phase, that is called CARS, that is compensatory anti-inflammatory response syndrome. As soon as an inflammatory response is there, and it should not be prolonged, it should not be too long in the body, so body gets one more to counter that SIRS, that is called CARS. This is compensatory. This compensates the inflammatory response which is present earlier. So this checks the earlier one. So as you know, there is a homeostasis in the body in every system. So this is a homeostatic mechanism which kicks in to reduce the SIRS magnitude. So it limits autodestructive inflammation. That's what we were thinking all these days, the cytokine storm and all, and injury to the uninvolved organs. If the response is more, if the inflammatory response is more, then unfortunately these collateral damage, these liver and kidney, they are unaffected by these injuries, but they were doing their own job. But they were now they are involved in this inflammatory process and they are made to stop. So the uninvolved organs are also made involved by SIRS. So that is being limited by this CARS. And like as I said, homeostatic mechanism, this is always proportional to SIRS. If the SIRS is more, then the anti-inflammatory response also should be more. If SIRS is less, this will be less. And this will lead to delayed immunosuppression. So once there will be immunosuppression, then definitely most of the infections can become normal commensals which are present in the body will become pathogenic, infective, and it may lead to multi-organ dysfunction syndrome. So there are several acronyms for you to bandy about and tease your friends from other colleges. You can say, can you tell me what is SIRS or CARS or MODS, all these things. Not your modern. This is our modern. That is multi-organ dysfunction syndrome. This is the one which is killing most of the patients, even in COVID. Patient is dying of heart attack. Patient is dying of cerebral hemorrhage. or liver failure or kidney failure. So those things are not there in the initial spectrum of things, but the body's response is killing. So these are some of the features which are involved in the initiation of SIRS and CARS. So which may lead to, if they are not controlled and if they are not balanced, what will happen we'll see. So this is a algorithm, and by the way, I think I drew this. Okay, so I wanted to have a personal touch. I don't want to get it from somewhere and keep it. So once I understand it, I just wanted to make it very simple so that all of them can easily understand. I think it's a self-explanatory. Here, once the insult occurs, then SIRS kicks in. Once SIRS comes in, then it will lead to CARS later. Then if it is balanced response, if SIRS is 50%, then CARS is 50%, then resolution of the problem. There is no problem. They can go home happy. Then coming to other area where SIRS is more but CARS is less, the inflammatory response is much more than the anti-inflammatory response, then that will lead to, that is called a hyper responsive state. The response is hyper. So this is the main reason why we are losing more patients in COVID also. This is the cytokine storm which is all everybody is worried about. And you never know who is going to show this hyper response, and which will this hyper response is nothing but a massive inflammatory response, and clinically this is known seen as hypotension and multi-organ failure and shock. Hypotension, all of you know, shock, and which will lead to prolonged hypoxia, will lead to multi-organ failure. Conversely, if the SIRS is very limited and CARS is more, anti-inflammatory if it is more, as we have seen, it is called a hypo response because response is limited. Then it will lead to persistent recurrent infection because it will lead to reduced immunity. If the CARS is more, see, a certain amount of inflammatory response is very, very essential to combat any infection. All of you should understand, if the pathogen comes into the body, then definitely these mast cells should go and phagocytose, and this PNML will go there, and all these things take place, and this is the normal inflammatory response. If this normal inflammatory response is reduced, or if it is hypo response is there, then it will lead to persistent and recurrent infection. So it should be in moderation. Like everything in life, this also should be in moderation. It should not be too low or too high. That will lead to multi-organ failure. Put in a nutshell, what happens? There is a first hit or injury, initial injury. Then there will be body response to trauma. So how do you know that body is responding to the trauma? Then you see immediate inflammatory response by observing the levels of IL-6 and IL-8. And if it is more, then it will lead to organ failure. ARDS, all of you know that respiratory difficulties will be there, fat embolism syndrome, all those things, or multi-organ dysfunction syndrome, which will lead to death. Or if the body response is adequate, then it will go to recovery. And what is this second hit? As we have already seen, as it is the patient is reeling from his first hit. Then if you are not careful in your management, you are going to hit him again with your unnecessary interventions. That is called a second hit, and that will lead to the patient going into all these complications. So you should hit him when all the conditions are suitable. It's like this. You have, I think all of you can identify this movie, and they are very famous actors at that time, and here the king was attracted by another lady, and that is the second hit in her life, the first wife's life. That's the second hit. Here usually, like in the movie, before you want to take that second hit. What is that second hit in this scenario? The surgical burden. So as soon as you get a patient with polytrauma and all these things are present, patient is already under shock and you are resuscitating, and if you impose unnecessary surgical burden on him, then definitely it will act as a second hit and you may lose the patient. So you should be very, very careful to choose when to operate in a polytrauma patient. If it is a single fracture, then there is no problem. You do all the initial tests, and even in that you see whether the patient response is adequate or more or whatever. Then taking all these things into consideration, you post him for surgery, and the anesthetist will do the pre and anesthetic checkup, and if he says go ahead, then you operate. There is no problem there. But in a polytrauma patient, you need to search for so many things, and you need to satisfy so many prerequisites before you put your knife on that. So this is the time where I think you should be in a proper state of mind before you take a decision in these patients. Like in this picture, in these times, whether in the dawn or during dusk, you should just relax for a minute looking at the wonders of the nature. This is taken outskirts of Hyderabad, and a beautiful picture. So once you see the nature, definitely you relax. So whenever you want to take some difficult decisions, either in life, in professional life or in personal life, I think you should give adequate time to your mind so that you can relax and take a proper decision. So coming to early total care. That means what is early total care? So this if you want to go down the path of early total care, then it should be done within 2 to 12 hours of the injury, because after that this inflammatory response will kick in and patient general condition may not be amenable for you to operate on that patient. So within 12 hours, if you can operate on that patient, you do that. You can completely do what is needed for the patient. That is early total care. That means you have a femur and tibia. Fix them. Fix both of them within 12 hours. Then that is called early total care. Even to do that, you should have proper equipment and the patient should be ready. So here the surgeries can be by a reamed nail or plating. So if it is a forearm, we plate. If it is long bones, we usually put a nail. So everything has its own complications, advantages and disadvantages. So you have to weigh these things in mind before you take a decision what to use where. And operation time. Operation time, if it is a nail, it can be done within say around 45 minutes. And if it is a plating, because it involves opening and dissection and so many things, so it may be around 2 hours. And each minute counts in these patients, and blood loss. So if it is a closed method, then the blood loss will be minimal. If it is an open method, whenever you open a fracture and you want to fix it, then definitely the blood loss will be more. And as you know that depends, blood loss depends on the fracture which is occurring in which bone. If it is femur, it bleeds more, and if it is pelvis, it bleeds much more. If it is a forearm, it bleeds less when compared with fracture femur. So all these things will be taken into consideration before you take a decision to go for early total care. But here, early total care, you cannot think of only fracture. Fracture cannot be isolated. There is a patient attached to the fracture. That means you should take the patient's general condition as a whole. just because you have seen a fracture, just because you know how to fix that fracture, don't go and fix that fracture. You have to take the patient as a whole. You should know whether the patient is able to take that second hit, and if the patient is unable to do that, then don't do early total care. Then what to do? Then this damage control orthopedics comes into picture. So here the 24 to 72 hour period or after the initial injury is the most important period. All of you know that the initial first hour is the golden hour. Whatever you want to do for the patient, you should do it off within first 1 hour, so that the next course of patient's stay in the hospital becomes very easy. If you don't do what is needed for the patient in the first hour, then it may be too late. Okay, but this golden hour can be extended up to 6 hours for normal resuscitation. But for a fracture fixation, we take it up to 12 hours. But after 12, we should be very, very jittery. If you want to fix a patient between 24 to 72 hours, so many things have to be taken into consideration. Here, there are two options: damage control orthopedics or early total care. Here, if you operate a badly injured patient who is not ready, then your surgery will be the second hit. Then you are increasing the chances of second hit if you opt for early total care in a patient who is not ready for it. Then you should resort to what is known as damage control orthopedics, so that the chances of second hit are reduced. And here in early total care, we stabilize the fractures and the bleeding whenever it is there before the danger period of 24 to 72 hours. So that once the fractures are stabilized, then the bleeding from fracture ends is cut down. Once that threat is gone, then I think the recovery can be as expected in from day 1 to day 3. So if possible, go for early total care. If you cannot do it, then go for damage control orthopedics. Coming to damage control orthopedics, what are the things which you should do? Of course, this is my handwriting. I think most of you recognize this. So what you should do, the initial step would be stop ongoing damage. That's what is all about. No, damage control. So limit the damage. How to do that? So if there is any compartments which are open, then release the compartments to prevent compartment syndrome. All of you know that leg, thigh, forearm, they have different compartments: anterior, posterior, medial, lateral, and they are bounded by musculo facial osseous tunnels like things. They are very, very watertight. So you cannot if there is any inflammation in one compartment, then it will lead to compartment syndrome. So if such a situation is there, you need to release the compartment so that compartment syndrome will not occur. Then if there are any dislocations, as we know that dislocations are an emergency, you should reduce them. Then if there are any open wounds, debride them. And if there is any fracture of the long bones or pelvis, then you can stabilize them by means of external fixation. And what are the things you should look for? Control the hemorrhage by whatever means, and fluid resuscitation. It's very, very important. You should try to restore the fluid balance. Whatever patient has lost, you need to replenish it. And then if there is any chest tube which need to be inserted, a chest x-ray, all these things have to be taken, x-rays, and all these things should be done to stop the ongoing damage. Then stabilize long bones. If it is early total care, you do nailing or plating and be done with it. But here you cannot go for that because it is long. It will consume a lot of time and there will be a lot of bleeding. So you cannot afford. Then you go for early external fixation. External fixation, you don't need to open the fractures. You put 2 pins above, 2 pins below the fracture and connect them. That becomes an external fixator. Once you do this, then re-evaluate and monitor the patient. What about his vitals? Is the shock is getting reduced, or his BP is coming back to normalcy? Is there any urine output? Is there any abdominal girth increasing? So many things you need to monitor. Then stabilize the physiology. That means you should be worried about the vitals. Vitals should be stable. BP, urine output, blood gas analysis, and all these things you need to be on the lookout for. So IL-6, sudden increase in IL-6 may show you that the SIRS is kicking in, or the magnitude of the SIRS, and what are the complications which you may get in this patient. All these things can be known. Once that is tided over, once damage control is done, then definitive stabilization can be taken up. Once patient is out of this damage, then you can do early definitive fixation. So that may be intramedullary fixation or a plate fixation. This is called MIPO. That means minimally invasive percutaneous plate osteosynthesis. All these things are high sounding, and if you bandy them in front of your friends, I think you can see the surprise on their faces. So try to remember a few things and show off. Coming to intramedullary nails. Intramedullary nails are, all of you know, one of the things which we routinely use because they provide excellent stabilization and they are mechanically very, very sound, and the results are predictable. Even if I do or you do or somebody else has done, once you do this, then definitely the results will be comparable, and complications are very minimal if done properly. But the problem with these intramedullary nails is, once you start reaming this, see, if you want to put a nail inside the medullary cavity, then what you should know what is known as reaming. You should send a reamer inside. You put a guide wire first from the proximal to the distal and see whether it is inside in both the views, AP lateral. Then you send a reamer over that guide wire, reaming this. That means it is tunneling. It is making a road for the nail to come in. So that reaming, and reaming is done by power instruments. Once you start reaming, there may be some chance of embolization. See, the small fat from bone marrow cavity, it may be sucked into the capillaries and it may reach the systemic circulation and may lead to some embolization. So this is a very live complication, and you should always weigh which is better for the patient. Okay, and this intramedullary nail becomes very difficult if you want to fix multiple bones. Multiple bones, if you want to do at one go, it will be difficult to do it, because the positioning which is required to do femur, then it will be you will be unable to fix the tibia. If you want to fix the tibia in that particular position, then femur cannot be fixed. So all these complications you have to weigh, and time and blood loss in a multiply, even intramedullary nails, they may consume a lot of time. If the patient is multiply injured and severe blood loss, each minute counts. So sometimes these are some of the complications by doing intramedullary nails. But when it comes to plate fixation, it is the best fixation of all, because you are opening the fracture and you are seeing the fracture. Under vision, you are going to reduce the fracture. In close reduction, here you don't open the fracture site. You just manipulate the fragments and you pass the guide wire, and reduction may not be 100% anatomically accurate always, because this is a closed reduction. But when it comes to plate reduction, plate fixation, it is a open reduction. You can hold both the ends of the bone with bone holders, and under vision you can keep them reduced and put a plate on it. So reduction is best stabilization, because you put screws above and below the fracture site, it will be rigid, and there will be minimum embolization, because you are not reaming under with pressure reamers. the embolization threat is minimal. And you can operate on a humerus, and if two teams can operate simultaneously on one forearm and one leg and one femur, like that. If multiple fractures are there, multiple teams can also operate at the same time. Like forearm, humerus, these are the common bones for which we usually reserve this plate fixation. But the problem here is highest blood loss, because you want to open the fracture site, take away all the fracture hematoma, and these, once you cut the skin, it bleeds, fascia bleeds, muscle, it bleeds. So there will be lot of blood loss. As it is, the patient has lost so much of blood, you are adding to his loss, and that it is exposed, it is an open, so time will be more, and temperature, as it is, the patient is hypothermic, and once the patient comes into OT, and from OT when he is going back, they more than 50% of the patients were hypothermic, because inside the OT naturally it will be very cool, because the surgeon, when he is operating, he is very hot. So then all of us, once you are in that zone and you wear a lot of protective gear from to save yourself from the radiation, that lead aprons, all these things will add to your discomfort. Then you ask the air conditioner to be around 16 or 18. So even with you covering the patient, but operating part must be open. So all these things will see to it that patient will be hypothermic when during surgery and after post-operative period. And sometimes there may be some iatrogenic injuries, and this can be because of the tourniquet. You need to apply tourniquet for some surgeries, and as it is, the patient is a bit hypoxic patient and hypoperfusion, and if you put a tourniquet in these patients, you may increasing the damage, and high complication rates are seen if you choose this method for lower extremity cases. So you are in a dilemma, what to do, when to do, so how to do, so many things. So this is a thorny dilemma. Then you can get out of this by doing external fixation. So you can tide over the emergency by putting an external fixator, and later on, if the patient survives, or if you are in a setup where you work in shifts. So suppose I admitted the patient initially, then I am worried about what to do, what not to do and all. So I excuse myself by doing an external fixator and go away. And somebody else who comes after me, then he may have a thorny dilemma whether to keep it for how long and whether to go for definitive fixation, when to do that. So all these things have to be very well thought of, because you take a proper decision. But by doing external fixation, you can be done away. This can be done very fast. So it is a rapid procedure, and very less amount of blood will be lost, because you are not opening anything. You are just putting some drill holes and putting some pins above and below the fracture and connecting them. But the main problem here is pin track issues. So pin tracks invariably get injured if you leave them for prolonged period. That is, if you leave them for say around 2 weeks, then definitely most of the pin tracks will get infected. So we need to take proper care. So external fixator, the advantages are easy to apply, but there are some things which you need to consider before you apply a external fixator. So here is an injury. Here is an injury. Here, this is the fracture here. This is the fracture hematoma. So this is the zone of fracture. This square inside. So the above square is zone of soft tissue injury. So up to here, soft tissue is injured. So we don't touch these things, because these things have to be taken care later. If you put a pin here, if you put a pin here, you may contaminating this area. So we steer clear of these areas. We go much away. So this is, say, this is Koti Junction. Very, very busy. You cannot touch. You cannot live there. So you go to Kompally. You go to Kompally here, or you go to Dilshuk Nagar and beyond. So these areas are not contaminated, and you are not contaminating the original wound by putting a pin here. So that's what we do. We put the pins here, and we be away from site of activity. So this is one example where this is a fracture and all soft tissue injuries, so many things are here, but our fixator is much away from all this. We are not contaminating, we are not jeopardizing the area which is injured. So this is how we have done this. So this is a muscle cover was given to an open wound, and this is away. This is like a temporary first aid. Once muscle cover is there, skin cover is there, then this is as good as a simple fracture. All of you know that a simple fracture, skin is intact. An open fracture or a compound fracture, skin is breached. So that breach in the skin is closed here. So this has become a simple fracture which we can take up internal fixation here. So once your external fixation is there, then you have to fix it. Definitely secondary fixation that should be done. That can be done maybe after 5 to 10 days. Once the patient physiology improves, then you can take him up for such definitive procedure and can operate on him, because we have prevented the contamination by keeping the pins away from the area of surgery. Okay, so sometimes you can give anesthesia even with this, all of you. I hope my lecture is not this for you guys now. Coming to multi-organ dysfunction syndrome, that is one of the most dreaded complications in a polytraumatic patient. So what are the reasons for this occurring in the first week? All of you know about fat embolism. We have discussed extensively about this in the class. That is one of the reasons which can lead to MODS or multi-organ dysfunction in the first week. Another one is hypoxia. If you are not able to reverse this hypoxia, then definitely it will lead to multi-organ failure. There may be cerebral depression, coagulopathy, renal failure. All these things will muddy the pitch and you may lose the patient. Coming to some examples. See, here is a patient, a 16-year-old who is involved in road traffic accident. As you can very well think, a 16-year-old on a road, how he will be. So he was involved in a high energy motor accident clash, and you can see the femoral head is out of the socket. This is a acetabulum. This is a fracture dislocation, and fracture is not on one side. Fracture is on both sides. See, for a patient to have a dislocated hip with fracture femur bilaterally, it needs tremendous amount of energy. That means it must be a high speed crash, and it's no wonder if you go to ORs and just wait there for some 5 to 10 minutes, you can see so many potential candidates vying for this honor. Okay, and this patient has pulmonary contusions as well, and the patient has traumatic brain injury. Traumatic brain injury, bilateral femoral fractures and hip dislocation. These were a recipe for disaster. And the patient, when he was taken in, and immediately early total care was done to him by reducing the dislocation. They should have stopped at that, but they went in and fixed the fractures by reaming. So this is a intramedullary nail, and as we have seen previously, you need to ream the bone to put in the nail. So they have reamed the nail, put in, and not only on one side, they did it on two sides. Then what happened? Patient developed florid ARDS after 96 hours because of the nailing. Then this is the autopsy findings. Then what happened to the patient? They lost the patient. So this is severe hemorrhage inside the lungs which led to his death. So now the main question is it inevitable or preventable? If that patient has come to you, what is the hurry in operating on that patient? That was a second hit, which is the cause for this autopsy finding. So there is something called a borderline error. So don't err on this side or that side. Don't be in a hurry to fix everything, or don't be in a leisurely manner, leave everything, we'll see tomorrow, or throw it on the next surgeon. But there is something called a gray area. Nothing is black and white here. There is a gray area wherein you need to take a decision depending on the hospital in which you are working, because most of the hospitals or state run hospitals, or for that matter most of the corporate hospitals, may not be battle ready. That means suppose there is a accident, mass casualty, 4 or 5 patients have come, then all hell breaks loose. Then definitely you don't have wheelchairs, you don't have trolleys to pull the patients in, you don't have saline stands, or you don't have enough IV fluids, or you don't have enough personnel to care for these patients. So we are not battle ready always, and our awareness levels are also very, very low, and the affordability of the patient. Once it comes to say corporate setups, then definitely sky is the limit for the billing. So the meter runs very fast. So here the affordability kicks in. Then technology divide. So what all is available in the West may not be available to you. So you have to make to do with what you have. So you may not have so many gadgets with you, but what all you have to make do with that. So all these things are considerations, because these things hit you in the face when a mass casualty or a polytrauma patient comes to you and you want to do your best to the patient. Then what is the place in damage control orthopedics? When you should think of damage control orthopedics? When the physiology is unstable, patient's vitals are not stable even with your treatment, then don't be heroic, don't go for second hits, be conservative, do whatever best you can do within your limitations. And in a multiply injured patient where life comes first rather than limb, and whenever there is a traumatic brain injury or brain bleed or raised intracranial pressure, go slow. So these are all the red flags which you should consider. Anyway, you don't consider any red light on the road, but here in this park you need to be aware of the red and the green and the amber. Whenever that amber is there, be cautious. If the red comes, stop in your tracks. Whenever there is chest trauma, mass casualty, you should opt for DCO, that is damage control orthopedics. Coming to the limb, in a limb, what is DCO? What is damage control orthopedics coming to a limb? If there is a isolated complex limb injury, that means a compound fracture with an arterial or neurological injury, that is called a complex injury, and the limb is not mangled, mind you. Mangle means, a severe crush injury or a train running over the extremity, that is all mangled. And if it is a distal femur, you can go in for a DCO or proximal tibia. There are more amenable for external fixator and all, Phylon fixator. Then you can go for damage control orthopedics. And here, what are the things which you should do to save the limb? Here, fasciotomies. You should open all the fascia so that there may not be any compartment syndrome. So you need to put external fixator much away from the injured area. That means you may have to span a joint sometimes. All of you know a spanning external fixator that is away from the wound, and it may span a joint. And you should use what is known as a antibiotic bead pouch. That means you need locally acting antibiotics. The antibiotic concentration which you give by means of intravenous route may not be enough to decontaminate the wound. So you need to use antibiotic locally. So there is a procedure wherein we use some antibiotic beads for this purpose. I'll show you what we do. And there is something called a negative pressure wound therapy. Here what we do is we seal the wound. We seal the wound airtight, and we apply a suction tube, and we apply a negative pressure. Thereby whatever little fluid is coming out, oozing out, we take it out from the wound, so that wound becomes dry. Once that is dry, then definitely the changes, that means the new tissue which is coming in, which comes up very fast, and more dramatic improvement on the wounds is seen with this. So these are some of the new techniques which we are using in combating this polytrauma and open wounds. So with this, with the help of all these things, nowadays we are salvaging more limbs than we are amputating. So when I was a postgraduate, the likely outcome in a polytrauma patient was amputation. And amputation is one surgery. No surgeon wants to do it happily. All of us are very happy to wield a knife, as I told you earlier. But this is one condition where I don't want to do this surgery in any of the patient, in any patient for that matter, because that's a I feel disgusted, I feel very bad for some days after. So if possible, I'll try to salvage the limb, and if it comes to inevitable amputation, I'll try to shift this responsibility to my neighbor. Coming to compartment syndrome, all of you know about compartment syndrome. You should have a high degree of suspicion to diagnose one. So all the P's, you know, that there will be some pallor, pain will be there, pulselessness, and poikilothermia, that means polar means cold, clammy extremities. There may be some paresthesias first, and if you don't bother, it will go to paralysis. This is about the P's in the compartment syndrome. Then you need to open fasciotomies. If you do fasciotomies and the muscle bulges out of the wound and it is pink, it is alive, then you are very happy. So this is the antibiotic pouch I am talking about. All of you know that there is one material called bone cement. This is not your ordinary Rossi cement or anything. This is bone cement. We have polymethyl methacrylate, and we add some antibiotic to it, like vancomycin or gentamicin, amikacin, or some things, because to make them antibiotic impregnated beads. We make some beads like this. These are not like your pearl beads available at Charminar. We made this, and we thread a thread like this. We made a garland, and this is an open fracture. We put external fixator, all of you know external fixator, and we fix these with K wires, and you can see the beads. This bone cement can be seen on the x-rays. So this is antibiotic bead, and after 6 to 8 weeks we take out this. So once you put this in the wound, then antibiotic will be oozing out of this bead, and it will make the area very sterile. It will prevent infection. We give IV systemic antibiotic, and we use antibiotic locally also. And once you take out, they will be like this. They're reduced in size. And are they effective? Definitely yes, because the local antibiotic concentration is around 50 to 100 times. So you can see here in the dish where the cultural, here this is the culture disc. Here normal amount of antibiotic is kept in the colony, and this is the area which is cleared. That means this indicates in this area this antibiotic is effective. This is how you get this culture and sensitivity report. You send a pus or something, out of which they make a colony like this, and they put this antibiotic disc, and this area of clearance shows this antibiotic is sensitive for this organism. But here, once these beads are put, you can see the area of clearance. It is much more than what you get in the lab. That means this is locally much more useful than by giving a systemic preparation. So you can keep that up to 6 weeks. So you can see the beads after their removal. So they are definitely effective. And this is the negative pressure I was telling you about. So this is the wound. We put a foam inside, which adheres to contour, and we seal it, and we will attach a suction, and there is a suction machine which intermittent suction, and it sucks all the ooze which is there in the wound. It will be something like this, and then what it does is it makes this a sterile environment by sucking out all the ooze which is there present and making it dry, so that the soft tissue can grow much faster in these wounds rather than if you leave them to the exterior. So I will show you some examples. This is a fracture of the femur, comminuted fracture, lower third femur. This is a very costly injury, open fracture. You can see this was there at the time of admission. So some semblance of debridement and some suturing was done. Then we washed it with a pulsy walk. I told you before, washing under pressure, pulsy walk, so that it cleans under pressure, so that lot of debris and all can be taken out. And this is when we put the external fixator. This is called orthofix, and some semblance of reduction is there. So this is the clinically after putting the fixator and closing the wound. Once you do all this, wound becomes so clean that you can even close it. So once you see this wound, we never thought we will be able to close this like in this picture. See? So these are all the marvels of modern medicine. Then we took out that external fixator and we pushed in a intramedullary nail inside. Okay, can you see this? And we put a bone graft also, because there is no continuity here. So there is some gap here. So we put some bone graft. And you can see the consolidation. The fracture is getting consolidated, and there is a bridging callus, as we have discussed in the last. This is looking a bit separate, but don't be in a hurry to take it out. Nature is so great that it is making some advances towards this, and over a period of time, whole thing will be incorporated here. Now the fracture is united, more or less consolidated, and patient is able to start doing his range of motion exercises. These are very important. This picture is very important when compared with this picture. I won't be very happy to see this picture, but I will be very happy to see the movements of the patient, because movements is life. So another word that is coming into O nowadays is early appropriate care. That means early total care, that is one concept, and damage control orthopedics is another concept. This is the in between. If possible, even after one day, if you are able to do early appropriate care. Don't do DCO, that is damage control orthopedics, and wait for some time. So you need to monitor the patient hourly to see if the patient is ready. Then go for early total care even after 1 or 2 days. That means early appropriate care. So that comes in between early total care and damage control orthopedics. So because our medicine is dynamic, so whatever we are teaching you today may not be applicable once you become a consultant. So now we see Hanover management of polytrauma. This is accepted world over. Here we divide them into stable, borderline, unstable, and in extreme. This is a patient condition at the admission level. So if the patient is stable, then definitely go ahead and do early total care. Fix whatever comes to your mind. If the patient is borderline, then control the hemorrhage, then do the chest compression, ATLS, then re-evaluate blood gas, blood pressure, urine output, IL-6 levels. If the patient becomes stable with all this, then go and do early total care. Even with all this, you are uncertain whether the patient is ready or not, then go for damage control. The other one is, if the patient is unstable and in extremes, then don't think of early total care. Go for damage control orthopedics. So now we have seen how to be a better surgeon. Everybody wants to be a good surgeon. Being a good surgeon means you do the surgery well. That is a good surgeon. You know all the steps, you know the anatomy, then you become a good surgeon. But I want all of you to become better surgeons. Then the good surgeon knows how to operate. He is very excellent with his knowledge of anatomy and his tissue holding and tissue handling, and he knows everything how to fix a fracture. So he is a very good surgeon. When to operate, he knows. But I want all of you to be a better surgeon who knows when not to operate. So if you know when not to operate, then everything else will fall in place and you can be a better surgeon. And if you work a bit harder, you become the best surgeon. So I want all of you to be the best surgeons. And thank you very much for your kind attention. And stress, don't take any stress which is not needed for you, and take it easy, relax, wear the mask, hand washing, physical distancing, no movies, no mall, no shopping, and stay at home, stay safe, take care of your friends, family, and your people who are dependent on you, like your ayas, malis, drivers. See, take care of them. Okay, thank you very much and God bless.